Hi, everybody.
Hi, thank you for joining us.
Can you guys hear us?
Yeah.
Perfect.
Okay, great. So I'm Dr. Horn.
Dr. V.
So we're going to go over diagnosis and management of meningitis. So this is a topic that we've had some requests for, that it's a very good topic to review. It's something that, we like talking about because it can be, so acute and something that needs urgent treatment very quickly. And we've gotten a lot of questions on it, so I think this is a good topic. If anyone has any questions for us, we'll kind of go through the subject, and you can always type in anything in the chat window, and we'll see your question and address it. Or at the end, if you'd like to unmute yourself and ask us any questions, we'd be happy to do that. So this isn't meant as a comprehensive review of meningitis. We wanted to just hit the main points and the main questions that we get that are frequent questions. So, we hope that it hits the topics that you're interested in.
Yeah. And before we were starting this webinar, we were just talking about how it's so important to start antibiotic as soon as possible for meningitis, and how every hour we delay, how their mortality goes up. So I think this will be a really good topic to kind of cover today. Yes,
and I'm glad you mentioned that, because that's going to be a theme. So that's something we like to repeat, kind of the important parts. And so the main point of the talk, if you get nothing else, is if you're concerned about meningitis, to start antibiotics early. A lot of the times people are taught, they don't want to tell us that they started antibiotics without getting an LP or without getting blood cultures, because they think, they've been always taught to do that.
Yeah, and one of the things is they're like, you need to get what bacteria is causing this, but it's okay to, our emphasis is going to be give antibiotics first, and then you could get, if the patient is unstable, then you could get all the other diagnostic tests. So
yes, the LP won't be normal anyway, but as the patient's mortality depends on how quickly they get antibiotics, that's going to be a main point. So we'll go ahead and get started. Whoa, went one too many. So definition of bacterial meningitis, and this is the one that's really the most urgent need to start antibiotics and to get diagnosed and managed quickly. So we're going to focus on bacterial meningitis. We'll also touch on viral meningitis and encephalitis, but we may have a separate webinar on West Nile virus, since that's another hot topic that people, Nebraska is one of the highest, if not the highest, for West Nile in the country. And so we may break that up into a separate webinar and discuss that separately, because
before the summer mosquito season starts.
Yes, that would be a perfect time to talk about it. So here, bacterial meningitis, inflammation of the meninges. So meningitis is inflammation of the meninges. In particular, the arachnoid, the pia mater, associated with the invasion of bacteria. You can get bacterial, viral, fungal meningitis. So fungal meningitis, really you only see that in people that are really immunocompromised, transplant patients, untreated HIV.
Or if a patient's on steroids for a long time, or nowadays we're using a lot of immunomodulated therapy for like Crohn's patients, ulcerative colitis patients, so they're also considered immunosuppressed, so they might be at high risk as well. So epidemiology. So during the last 20 years, the pathogens that we get for bacterial meningitis has changed a little bit, especially Haemophilus influenza type B. This was one of the biggest culprits in kids to cause meningitis, endocarditis, bacteremia, epiglottitis. It was a major pathogen. But since we started vaccinating for Haemophilus influenza type B, this has come down really nicely now. So now we see Haemophilus influenza non-typeable species, but they don't cause meningitis as used to be the type B. So thankfully we have a vaccine that prevents meningitis and other complications from Haemophilus influenza. But then the highest risk for meningitis, who are in the general population, it's our kids less than 5 years of age, or it's our adults greater than 60 years of age, or it's our immunocompromised patients, And then there are some other people that can be high risk too. If they lost their spleen, then you get into, they're high risk for getting encapsulated infections. Or if you're malnutrition or sick, also sometimes you are predisposed to getting meningitis. But the biggest group is, usually less than 1 month, babies, newborn babies, and over the age of 60.
So as with any infections, how do people get it? It's either hematogenous spread, which is essentially the bacteria goes through the blood and then lands there and starts growing. So it either spreads through the blood or it's localized spread. So localized spread would be like if a person has a head injury, if a person has a neurosurgery, if they have something that causes it to spread from the outside in. Other examples would be sinus, if they have really chronic sinus condition that spreads into the brain, ear infections that spread they go into meningitis. So these are the most common. I mean, with any infection, you're thinking hematogenous or localized spread. That determines and helps you, decide antibiotics, because it's which bacteria are commonly hematogenous spread into meningitis, or which bacteria, if it's a chronic sinus problem, which bacteria would be there to cause the problem, or an ear infection. So that helps you to decide which antibiotics would be most helpful for that patient. And we'll talk about this more when we talk about which bacteria in which clinical cases.
So this is a really nice slide kind of showing us what are the bacteria we have vaccinations for, and what are the bacteria cause common meningitis-like symptoms. So if you guys think about Neisseria meningitidis, when you get Neisseria meningitis, it's pretty bad. We are going to get into it a little bit later. You have severe meningitis-like symptoms. And usually the age group it targets is young adults. And we have vaccine for Neisseria currently. If you guys remember, it used to be that, young adults before they went to college, they got meningitis vaccine. But now the CDC has changed their recommendation. So kids as young as 8 to 9 years of age are getting meningitis vaccine. To prevent this complication, they get two doses. And the highest risk for getting Neisseria meningitis is if you live in dormitory, if you're a military recruit, you're in a closed environment, if you go to a Hajj pilgrimage in Mecca, so in like close area with lots of people, that puts you at high risk for getting Neisseria meningitis.
And this is the reason why we put people into precautions when they come into the hospital, why we put them into isolation. This is the one we're worried about.
Yeah. Definitely. And, that's a really good point. So infection prevention wise, if you are suspecting meningitis in a patient, it's really important to put them in isolation until we figure out what is causing the meningitis. Because, for example, if it's Neisseria, you don't want your employees and other people exposed to Neisseria. Usually with bacterial meningitis, after 24 to 48 hours of antimicrobial therapy, you could take them off of isolation because now you have killed the bacterial load.
And if, Neisseria meningitis can be normal in the upper respiratory. So if you went around and you tested people and you said, we're just going to culture, do a nasal swab, and then we're going to culture it and we're going to see what people have. Up to, I think, 7% or so people just normally have Neisseria meningitis. And they do this actually in med schools sometimes, where they'll do a swab and then they'll go to the person, they'll say, this isn't causing you problems, but at some point this could, be life-threatening. This could all of a sudden become pathogenic and get meningitis and cause a life-threatening illness. And they say, is this something you'd like to be treated for? The CDC would say, you don't need to be treated unless it's causing a problem. But if you're told you have something like this, this bad in your nose that could either affect you or your child or something, then
so
it's
this
kind of
is why
story.
You don't want to screen everybody for unnecessarily, because we're going to find things. But it is kind of interesting to know 5 to 7% of people are colonized with Neisseria in our oral pharyngeal area. Next bacteria is strep pneumo. So strep pneumo is the #1 cause of meningitis currently. So strep pneumo causes meningitis in children, or usually over the age of 1 month, one of the most common bacteria, and in elderly. And again, that's one of the, and strep pneumo is the big bug for pneumonia too. Strep pneumo is bad. But thankfully, we have vaccinations for both kids and adults. And if you look at some of the trends from CDC, because of the vaccinations efforts we have done, strep pneumo meningitis has come down tremendously. It's still the #1 cause, but the rate has come down.
Yeah, so whatever you give, you want to make sure that you're covering for strep pneumo.
Yes, exactly. Haemophilus influenza, usually children, and because of the vaccination, that trend has gone down. Streptococcus agalactiae, or we call it group D strep, that's usually the biggest culprit for kids less than 1 month of age. There's no vaccine for that, but kids get that through the vaginal canal, through the mom. So that's one of the reasons a lot of moms, when they're pregnant, they're screened at 36 weeks. They get a rectal swab to see if they're colonized with group B strep, and they get treated if they are, to reduce this risk of our babies getting group B strep infection. I think that rate has come down nicely as well with all the interventions we're making. And the other two big bacteria that play a role in neonates is Listeria and E. coli. Again, found in the vaginal canal, but the Listeria also elderly patients. But one other thing for Listeria is also in pregnant women and an immunosuppressed patient. So Listeria, we'll get into what type of treatment to do for Listeria, but it's really important to keep in mind Listeria is also a meningitis pathogen.
Yeah, and when they talk about, so here it says transmission food products. So this is why they recommend to pregnant women not to have cold cuts.
Yes.
I think
unpasteurized
cheeses.
Cheese, yeah. Because it's a big culprit in those products, and then if they could get pretty sick, and then they could transmit it to the baby too.
So if Listeria is there normally, if you have a healthy, good immune system, your body will take care of it. But for pregnant women at higher risk, those are women that you want to make recommendations not to have those certain types of foods.
Yeah.
And then we'll also see how this affects treatment in a second. Yeah. So here are clinical features. The classic triad: fever and a headache. So this is fever, neck stiffness, and altered mental status. So anytime you have someone, now this is the classic triad. This isn't seen in everybody. So here it says classic triad is present in less than 50% of adults. So if a patient presents and they say, they have a bad headache, they have a bad fever, their neck, if you have them move their neck back and forth, so you say, can you touch your chin to your shoulder? And then if they say that hurts, or they refuse to do it, and they say, no, I'm not doing that because it causes too much pain, that would be a positive sign, I think. But anyone that comes in with fever and a headache, you want to have a high suspicion for meningitis. You want to think, what is the worst thing that this patient could have? And my bacterial meningitis is one of the worst.
And when they have the neck stiffness, it's very impressive. Any little movement is really painful, and they're pretty stiff. And so I think doing a good physical exam when you have a clinical suspicion is extremely important.
And it has 1/3 of patients have neurological signs such as seizures. This would be a neurological sign like a paresis of a limb. 70% have impaired consciousness. So photophobia. So sometimes you'll come in to see the patient and the lights are off, and the patient will be, they'll be covering their eyes, and they'll be lying in bed, and they don't want to move, they don't want to talk to you, they don't want to do anything. So if you turn on the lights and they scream or something like that to turn the lights off, that's kind of something that happens often when we see these types of patients.
It's pretty classic. A lot of patients are like, the light bothers them so much, and I see a lot, this is just me anecdotally, I see a lot more of this with like herpes encephalitis patients too. They really have bad photophobia.
Yes, and they don't even want the lights on in the room.
Yeah.
So that's photophobia. And then phonophobia is when they don't like hearing loud sounds or talking loudly. There's no music on in the room. So it's photophobia is light hurts their eyes. Phonophobia is noise hurts their ears, and vomiting. And all of these, a lot of times when people see this, they'll say, well, how do I tell this is different from a migraine? Because migraines, many people have migraines, and they'll say, this is exactly how I was with a migraine. but you shouldn't be having a fever. You
Yeah.
shouldn't be having a high white count. Yep.
Yeah, you shouldn't white count, fevers, neck stiffness. That shouldn't be with migraine. Yep, absolutely.
Right. So, you know, when I see somebody, I'll say, "Are you the type of person that has headaches?" And they might say, "No, I've never had anything like this. This is terrible." And they're oftentimes very upset or angry, and they're just not in a good place.
Yeah, because there's just so much discomfort and pain.
And oftentimes, if you look at them, they look sick. Like you just look at them and you say, "This person is not well," which is also another way you can differentiate it from migraines.
So meningococcal meningitis. So one thing to remember is it needs to be reported to your health department, because you know, if you do have somebody with meningococcal meningitis, then the health department will do contact investigation and make sure they look at, you know, school exposure, work exposure, so then we could make sure close contacts get prophylaxed. High risk, again, college dorms, military barracks.
And one that's not on here are lab workers that work in microbiology labs, if they see it frequently. So there are some labs that see meningitis and they grow it up in culture frequently, and those people are high risk and they could consider getting a vaccine.
Yeah, so that's a really good point, because some labs, when you do work on the petri dish, you work under a hood. So then you're protecting yourself. But some labs don't have proper, you know, they don't have that hood set up. So then if you have a lab worker, then they could be exposed. So some of the recommendations, like you were saying, is that if you're a person that is constantly working with lots of different culture in the lab, and if you're going to be exposed to the different organism, that you do get vaccinated for meningococcal meningitis. And that was one of the things that we did in one of our hospitals, that for our lab workers, to make sure they got meningococcal vaccine.
And each lab is going to be kind of looked at individually. I
Yes,
wouldn't say every lab worker needs to go out and get a vaccine.
That's why it's really important to know, like, where do you work, or how do you do your culture? Do you work under a hood, or do you work in the open space? And what are your risk factors? Yes, you're right. Not everybody needs it.
And so this next part about rifampin, so these are, if someone comes in and they have meningitis and it's found out to be meningococcal meningitis, then you look at it and you say, wow, this is so contagious that we want to give prophylaxis, so they're close contacts so they don't get sick. And these recommendations actually came from Creighton. They actually, when they swabbed the med students, the med students were used kind of as, well, I'll just say they did this with med students. They swabbed their nasal canal, and they looked at it and they said, what percentage, it was about 7% of the students were meningitis growing just normally, and they gave them rifampin or Cipro, and they looked at mainly, I think, rifampin and Cipro, because they were looking at PO, ways to get rid of colonization. And rifampin, Cipro both worked, and so from that study, they said this should be used as prophylaxis to prevent infections in close contacts.
And that's really important what you just said about close contacts. So let's say that, you know, we have a patient with meningococcal meningitis, and you know, you were in that room, you just stayed by the door, patient's on the bed, you were more than 3 feet away from the patient, and you had no contact with their secretion. You don't need prophylaxis. But let's say the respiratory therapist who intubated this were part of the intubation team and then did suctioning, they were extremely close and was exposed to a secretion. So they will need prophylaxis. Sometimes. That's
a really good point.
Yeah.
So this is a common test question at all levels. Yes. I've seen it at all levels, where they'll say, patient comes in, they're found to have meningococcal meningitis. Who should get prophylaxis? And they'll say the nurse that admitted them in the ER, that saw them when they first came into the ER? Should it be the person that brought them up to their room? Should it be, and they kind of have a list, they'll say the college professor that taught their course, right? Or everyone in the 400 students in their college course, or the girlfriend, or the person that intubated. And Well, I kind of put a trick question there. So that it's the person that intubated. Whoever intubated the patient, whether it's the person in the ambulance, whether it's the ER doctor that intubated, because they have to get right up close to the patient to intubate them, they're so close that they're getting their secretions all over their face. It's the person that did the intubation
and the
boyfriend or girlfriend. Yeah.
Yeah.
So the boyfriend or girlfriend, you assume that they've been kissing or they've been in close contact. And then as far as others,
it depends
really,
on cases
depends.
and
Yeah.
if they had any secretions and how close contact it was.
Yep.
But whenever there is a concern for meningococcal meningitis, everybody gets really anxious and worried.
Yep.
And I think the key is to calm everybody down and kind of figure out what close of a proximity they were there. Yep. And if they were close proximity, giving prophylaxis pretty much clears you of that risk of developing. There might be a small percent of you getting the infection, but it's extremely small because prophylaxis really helps eliminate that.
Yeah. So just people that have had close contacts, but to alleviate risk and or anxiety and everything, and sometimes healthcare workers that come up and ask for prophylaxis, we can talk about it, but sometimes they're very well informed and know the risks and everything, and So here are some examples. This is Neisseria meningitidis, and we wanted to put this out there because this is one of the extremely bad complications from Neisseria. Now this is Neisseria meningitidis, this is meningococcemia, so this is not only so there's Neisseria meningitis, and then meningococcemia is when it gets into the blood. So they could have one but not the other, but this is such a bad complication, and you read about this in the news. They come out with these horror stories that really are horror stories that it happens so quickly in just a matter of hours. And sometimes in the news they'll come out and the news article will say there's a college student in their dorm, they wanted to stay in bed, they didn't go to their classes, their roommate didn't think much of it, they come back later and they have Neisseria meningitidis, they have this horrible rash, and they're groggy, they won't wake up, and then they take them to the hospital. And do you see this picture with the fingers? Sometimes it'll cause such a poor perfusion and bad infection in the fingers, they'll have to amputate the fingers or amputate a limb. And it can be so bad that this is very important to recognize quickly and make sure that you have them treated very aggressively. And this with the glass here, this is, you can use a glass or you can use a slide. This is trying to show that when you push on it, the redness doesn't go away, that the redness stays there. Okay, that's why they're using the glass there.
So lumbar puncture, this picture is just to show how to do a lumbar puncture in a lying or a sitting position and how to do it sterile lumbar puncture. Lumbar puncture is introduction of a hollow needle into a subarachnoid space of the lumbar portion of the spinal column.
So they can either be sitting up like this or lying down. If they're sitting up, you can't get the opening pressure. You really want them to have lying on their side for the opening pressure, which we can talk about in a second. It helps you kind of see how, well, we'll talk about it in a minute. But to get opening pressure, they put the needle in, and the fluid will go up, and as high as it goes, that will help you to see, it'll have a number there, and then you can look at that, and that's the opening pressure. That's how much pressure is there in that space. And
the reason for that is usually we have a normal pressure, less than like 20, but then if your opening pressure goes up, that shows you have more pressure building up in the spinal canal and the fluid area, which is another indication sometimes in fungal infections and such, that if that does go up, you might have to do multiple lumbar punctures to kind of bring the pressure down. Because the higher the pressure you have in your CSF area, you could have some shifting of your brain and can cause more compression. So it's really important if there is a high opening pressure to bring that down.
So here's just another picture with it. So the needle goes in, you get some of the CSF fluid out, and you can measure the opening pressure. And the normal pressure, it says here, around 15 to 20. Yeah.
This slide is really good. It just talks about what kind of opening pressure do you get if you have bacterial, viral, or fungal CSF infection. So for all of them, you will have increase in opening pressure. But what we have seen is that with fungal and TB, it's really high opening pressure. And when my attending taught me this, one of the reasons is when fungal organisms multiply, they take up so much space in the small area of the CSF area there is, it just creates so much pressure because they're constantly multiplying. So definitely fungal organism causes higher opening pressure, but they all can cause high opening pressure.
And then when it comes to cell count, now this is the predominant cell count. So 0 to 5 cells in the CSF is normal. So if you only have 0 to 5, say if you have 0 to 5, sometimes we get called and they'll say they have 4 cells and they're all lymphocytes. So that's normal, and you can disregard the lymphocytes, because we'll get a call and they'll say 100% lymphocytes. Do you think this is viral or fungal? And we'll say, well, if it's only 0 to 5, don't worry about it, that's normal. They don't have evidence of inflammation. So the meningitis, inflammation of the meninges, having a big response with a lot of cells there. So I wouldn't worry about it.
So usually we start worrying about it when the white blood cell count in the CSF is more than 5. Like Dr. Hohn was saying, anything between 0 and 5, very extremely low suspicion.
And then protein, it can be high with all of them, but especially high in bacterial or fungal meningitis. And I don't know, I just think that's because there's a lot of bacteria or fungal that have extra proteins in there.
Yes.
I try to simplify things as much as I can. And glucose, the same thing. The bacteria and the fungal or TB, they're eating that glucose and they're causing it to be low.
So usually it's really important when you guys are doing a lumbar puncture and the test to get a serum glucose at the same time as the CSF glucose to figure out, because sometimes you might have a diabetic patient and their glucose, or hypoglycemic patient, and their glucose is 30 and you're worried, but their serum glucose was only 50. So it's really not that low. So it's really important to compare serum to the CSF glucose. And if the glucose is 2/3 less than what it's supposed to be in the CSF, then you kind of start worrying.
So you could just do a finger stick glucose.
Yes.
About the same time you do the LP.
Yeah.
So sometimes people will get the LP, but the glucose they had was from the morning or something like that. Yeah. So just do a finger stick and then you've got it. So we included this because we want to have some actual numbers instead of just saying high or low. Sometimes this can be overwhelming, but it gives some actual numbers. I like the other one for just a generalized looking at it. Now, one thing that kind of makes it maybe a little bit more difficult and not as straightforward is when you look at this one, it's not just looking at one of the variables, it's looking at all of them and taking it kind of into account, kind of like a comprehensive everything.
And one other thing is to remember that for bacterial meningitis, it's usually neutrophils that are really high, and viral and fungal, it's lymphocytes. But it's not always the case, because a certain fungal organism you could have neutrophils too. But in generalized bacterials, you get neutrophil. Other ones you get lymphocytes.
Yeah, and that's what makes this a little bit confusing, is that this doesn't have to be across the board correct, but just in general, taking it into account the clinical picture and how's the patient doing and everything like that. So we include this kind of as a reference to refer back to, but not something we want to go over too much.
So viral meningitis, one of the most common form of meningitis, CSF usually predominantly shows lymphocytes that we talked about, and maybe a mild increase in protein, maybe normal glucose. But the big virus that we really worry about, that we could do something about, is herpes, herpes 1 and 2. So if you are worried about a viral meningitis, the best test to use is PCR in the CSF for herpes 1 and 2. Long time ago, we used to use viral culture in the CSF, and that took many days. PCR will come back within 24 hours. So it's really important, if you suspect herpes meningitis, to start them on antiviral. acyclovir, because if you wait to the results to come back to start treatment, they could have devastating consequences and have brain damage. So it's extremely important if you're suspecting herpes meningitis. You know, they had recent cold sores, they have history of cold sores, now they're meningitis-like picture, to cover for them and test for it and wait for the test to come back.
Yeah, it's almost, now you have meningitis and encephalitis. Yeah. Encephalitis is almost like a stroke.
Yeah.
I mean, they're may not have any recovery at all, really, even if you treat it really well with acyclovir. So you want to make sure you get acyclovir on board and kind of keep it there. I kind of maybe overtreat with acyclovir because if a patient has HSV 1 or 2, meningitis or encephalitis, you want to make sure that you treat it really aggressively, because encephalitis, they may never recover.
Yeah, exactly. It could be very devastating. So what we always do is, if I'm suspecting meningitis, encephalitis, start acyclovir, send for testing for herpes, wait for the test to come back, and if the test is negative, then you could stop. But caveat is, if you're still suspecting for herpes, even if the first test is negative, if you did it in the first 1 to 2 days of symptoms, but you're still worried about herpes meningitis, one of the recommendations is that you re-tap the patient at 5 to 7 days to make sure it's still not herpes meningitis or encephalitis.
Right, and sometimes if you have a very high suspicion, you might get an MRI, and the MRI will light up. And it doesn't light up every time, but if it lights up in the temporal region, then you'll say, that would be consistent with an HSV meningitis.
Temporal right here likes to light up for herpes.
And we just wanted to mention Mollaret's meningitis. This is something that it's frequently on tests, and essentially patients can get repeated meningitis and come back every so often with a meningitis that kind of reoccurs. And Mollaret's has 2 L's, and so I think HSV2, because it has 2 L's, I think HSV2 is the most common that causes Mollaret's. And so you treated from a meningitis, they could come back months or years later. You treat them again for meningitis, and if they have repeated meningitis with HSV2, then it's called Mollaret's meningitis.
And one of the hospitals I talked to, they actually had a case like this. And something to remember with Mollaret's meningitis, it happens in females during their period time, where they could have reactivation of the HSV2, and then they could cause Mollaret meningitis as well.
So it causes a viral meningitis. So here it has common and less frequent. So different studies see different things. Really, usually it's HSV 1 and 2 and enterovirus are usually at the top. But I just wanted to show this just to show there are other types, and there are many different types of viruses that can cause meningitis. The only ones you'd really need to treat if it's viral would be herpes with acyclovir, HSV 1 and 2 acyclovir, or influenza with oseltamivir, with Tamiflu.
And in rare cases, we don't see this often, but if you get CMV or EBV, then we have drugs, ganciclovir.
Yep.
Fungal meningitis. One of the big fungal meningitis that we see in immunosuppressed patients is cryptococcal meningitis. Usually it happens in a lot with our HIV patient or immunocompromised patient. Usually they come with headaches, fevers, neck stiffness, and when you do lumbar puncture, sometimes you will see actually they could look at the stain, they will see fungal organisms. If you do a cryptococcal antigen in the blood and the CSF, blood is more sensitive than CSF, that might go positive. So it's really important to keep in back of our mind fungus or fungal meningitis can happen. And if the patient is immunosuppressed, Cryptococcus is one of the big ones to happen. Of course, there's other fungal organisms that can cause valley fever and things like that, coccidiomycosis, but Cryptococcus is one of the big ones. And treatment for cryptococcal meningitis is dual treatment with liposomal ampho with flucytosine.
So these type of patients, so patients that get this are usually really immunosuppressed. So if a patient is a transplant patient, now really immunosuppressed patients, transplant patients, untreated HIV, they may not have the same signs and symptoms. They may not have a huge fever, a really bad headache. They may just have a slight headache every once in a while for the last month or so, but they may not come in complaining of something, that's as horrible or look as sick as other patients. But if you wanted to do a cryptococcal antigen in the blood, you could say, I'm not sure, but I want to check an antigen in the blood. It's like 100% in those patients.
So we did have a guidelines that was released from our Infectious Disease Society of America. So this guidelines is very good as reference. It's practice guidelines on management of bacterial meningitis.
So we just wanted to touch base on kind of the timeline or the algorithm when the patient comes in and you're suspecting bacterial meningitis. And this is now so many providers, there were kind of reviews about this. So many providers don't do this correctly, that they're actually thinking about taking out CT altogether, because so many patients get a CT scan and then antibiotics are delayed. And antibiotics are the most important thing for bacterial meningitis patients. So if a patient comes in and you have suspicion for bacterial meningitis, the first question on this algorithm is, do they have something where you'd worry about a space-occupying lesion? So these are all conditions that might make that more likely. So if the patient has immunocompromise, like untreated HIV, they might have a neoplasm, or they might have toxoplasmosis or something in the brain causing space-occupying lesion. New onset seizure might have high pressure in the brain. Papilledema, it's from high pressure in the brain. Altered consciousness, any kind of neurologic deficit, anything at all. And this is something that if they have any of these things, if you did an LP, so you're relieving pressure lower down in the back, then the pressure up in the brain might push down because you're relieving the pressure in the back, and then the brain pushes down, and then it's called herniation, where they can't breathe, and then they all of a sudden have a bad outcome.
Yeah, so we call it tonsillar herniation, where your lower brain area herniates down and it collapses, so you cut off the breathing. So it's really important to think about that. So you don't want to do a LP and relieve that pressure immediately and cause that bad outcome. So that's one of the reasons that you need a CT. Mm-hmm. But the point is, you don't need a CT
for everybody else. Well, yes.
Yes, immediately, or everybody else. The point is, while you're thinking about doing that, give them the antibiotics.
Yes, and this is something that everybody talks about, that everybody's worried about herniation. I've never seen it, I think, but the thing is if it happens, it's devastating. Mm-hmm. So in these types of patients, you'd want to get a CT scan. You'd want to give antibiotics, then do the CT scan. Mm-hmm. Then if the CT scan says that they're okay, then do the LP. But so if they don't have any of these things, you do the blood cultures, you do the LP, you give the antibiotics, and if you're going to give steroids, which we'll talk about in a minute, you give it then. Then you can kind of go from there. You look at the CSF findings, and then you decide if you want to scale back the antibiotics or take them off altogether. And on the other side here, if they have any kind of concern for higher pressures in the brain, then you do blood cultures, you give the antibiotics and steroids, then you do the CT, then you do the LP. So the LP won't be normal, and especially with, some facilities have biofire, then they'll have a positive biofire, and even if the blood or the CSF cultures remain negative, the biofire may have it on. Be able to identify.
And the nice thing about biofire these days is it's a PCR, so even if the bacteria is dead, it could still pick up the dead bacteria's DNA. But another thing to remember, even if you did give a dose or two of antibiotics, for most part, the bacteria you're going to still find.
Yeah.
So the key is to give antibiotics.
Yes, I mean, that's kind of a long algorithm, but if you just keep in mind, I don't want anything to delay the antibiotics. And there was an ER doctor that once said to me, in a busy ER, things can kind of get lost, or they'll forget about something. Usually in busy ERs, the reason people thought that they'll do a CT scan, then the LP, then the antibiotics, that's the incorrect way of doing it. They'll say, oh, my ER isn't too busy right now. I'll send them the CT scan, I'll call the radiologist, and then I'll do the LP, and it'll get done very quickly. But then they have a trauma come in, their ER gets busy, and then an hour or two later they go, oh my gosh, I forgot about that patient. And that's very bad. So I've had an ER doctor say to me, if a patient comes in and I'm concerned, I order the antibiotics, 2 grams of ceftriaxone immediately, and nothing delays it.
Yeah.
And I find that hard to argue with, because if it were me, I mean, the one thing that's going to save their life, that's going to increase their mortality, improve the mortality, is going to be the antibiotics. So I can't argue with that at all, since it helps the patient.
And I really like this slide. This slide kind of talks about what antibiotic do we start empirically. So it's pretty nicely laid out. So if you're less than 1 month of age, the biggest bacteria, like we talked about before, is Streptococcus agalactiae, group B strep, E. coli, Listeria, and Klebsiella species. So for our babies, ampicillin and ceftriaxone is perfect to cover for all these organisms, because the ampicillin is for the Listeria, and ceftriaxone will cover the other organisms. Or ampicillin plus an aminoglycoside. So a lot of babies also get AMP plus GENT, so that's okay. If you're between the ages of 1 to 23 months, you see a change in the pathogen. Now you have the number 1 as strep pneumo, then you have Neisseria, group B strep, Haemophilus, E. coli. In this case, again, you do Vanco plus a 3rd generation cephalosporin like ceftriaxone. You might ask, why are we doing Vanco? And a lot of times is when we're teaching students, they always say it's for MRSA. But it's not for MRSA, because as you could see in the pathogens, MRSA doesn't play a role. The reason for Vanco with ceftriaxone is because a lot of strep pneumo are becoming resistant to ceftriaxone. So we're trying to double cover the strep pneumo species. So that's really important. That's why we do Vanco and ceftriaxone.
Yes, and that's a really important point that many people don't really understand too well. But strep pneumo is at the top, and so you want to make sure you cover it. And MRSA or Staph aureus, you don't really see unless you have a head injury or localized spread.
And again, if you're aged between 2 and 50, the big bacteria is Neisseria and strep pneumo, so Vanco and ceftriaxone. And remember, if you're over the age of 50, it's the strep pneumo, Neisseria, but now you get into Listeria again. So that's why you do Vanco, ceftriaxone with ampicillin. So ampicillin is for Listeria if you're less than 1 month or if you're greater than 50 years of age.
And the ceftriaxone, its dosing is 2 grams BID. And that's something else that, another point that a lot of places make a big deal about is the dosing and making sure you understand you're treating them very aggressively.
Usually the nice thing about ceftriaxone is just once a day, but for meningitis, you have to do it twice a day.
And then here's some other kind of clinical scenarios where you would consider other antibiotics. We wanted to include it just so you have it more as a reference than anything, but head trauma. So for head trauma or penetrating trauma, so if patients in a car accident, they have a really bad head injury where they have localized spread of bacteria, if they have, it could really be almost anything. If they have essentially localized spread, any bacteria that's on the outside that can get in.
How I usually think of it is if you have head trauma, neurosurgery, CSF shunt, instead of doing Vanco and ceftriaxone, do Vanco and cefepime. So then you just increase the coverage to add the pseudomonal coverage.
Yeah, and that's a really good way to do it. And so here's vancomycin plus the cephalosporin, like 3rd generation ceftriaxone, but just increase it to the 4th generation to cefepime. And you can do that for these types of patients, for transplant patients, for patients that are untreated HIV, any immunosuppression that you're worried about. So here's post-neurosurgery. Again, it could localized spread, CSF shunt. Yeah.
And this slide is pretty much like the slide earlier. It just gives you guys the recommended therapy. For strep pneumo, you have to do Vanco with ceftriaxone. For Neisseria, once you know, a 3rd generation cephalosporin like ceftriaxone is fine. Listeria, you want to do ampicillin.
And this chart is good because it also gives you an alternative. So if the patient has a penicillin allergy, we've gotten that question before also. What do I give to cover Listeria? And here Bactrim is a good alternative, or meropenem.
And Haemophilus, again, a third-generation cephalosporin, ceftriaxone, E. coli, third-generation cephalosporin. So you guys have the recommended therapy and the alternative therapy.
So steroids in children, this can get a little complicated. I would recommend if you have meningitis in a child, you'd consult an infectious disease, a pediatric infectious disease doctor, to talk to them about what they recommend as far as steroids and everything go. Now, some of this is, and you can always call us and we'll get you in touch with a pediatric infectious disease doctor.
And the steroids, there's some controversies, but you know, for Haemophilus influenza type B, they do recommend steroids for kids. For strep pneumo in kids, they recommend steroids, but they don't see a lot of benefits with it. So, you know, in these type of cases, definitely consulting with a pediatric infectious disease docs is important. But in adults,
yeah, in adults, well, here's adults. So recommend use of steroids, and really the only time you would keep, so you want to only use it, the best outcomes using steroids have been shown when you have strep pneumo. So if you have strep pneumo, then steroids help those patients. But if you don't have strep pneumo, then you wouldn't start the steroids. But we don't know when you first see the patient, so you'd start the steroids
with antibiotics.
With the at the same time, right?
Yeah.
Right when you give the antibiotics, and then once you've done that, when you get the culture back, the results, if you have strep pneumo, then you'd continue the steroids.
Yeah. You know, and the reason for steroids for strep pneumo is that patients who get strep pneumo meningitis can end up having hearing loss. So the steroids are shown to help with that. So in a lot of developing countries, they don't even bother about steroids because their goal is give the antibiotic, get the patient better. But in developed countries, you know, one of the big things is give steroids with the antibiotic. So we, you know, long-term consequences of hearing losses and things like that, we could help.
Right, and when I think of things, I like to oversimplify because I like things to be as simple as possible. So people will say, well, why do you get deafness, or why do you have these problems? So, and like I said, I oversimplify. So the nerves come out of a very small hole in the head, and with all this inflammation, there's this inflammation that cut off the blood supply, and then you have that's where you get the deafness and everything. So
then you give the steroids, calm it down.
Calm it down, right? You don't get as much inflammation, and then you don't get as much deafness. So that's the simple way I like to think about it. And that's...
Yeah, so that's all the information we had today. I know it was a lot to cover, but we kind of wanted to go over some of the main points. Do you guys have any questions for us now?
Sure. If you have any questions, you can either type it in into the chat bar, or go ahead and unmute yourself and ask any questions that you have. But
and we recorded this talk, so we'll make sure to put it up so everybody will have it as a reference for later.
Yes, it's no. So, and we encourage you, if you have any questions, you can always give us a call. But starting antibiotics right away, and then kind of sorting it out later. And people will try to say, you know, well, what about, you don't want to start too many antibiotics because of antimicrobial stewardship, and then being too aggressive with antibiotics in meningitis or septic shock. But the antibiotics make such a big difference right away that I would recommend, you know, if you're even concerned about it at all, start the antibiotics and sort it out in the next day or two, because you want to de-escalate quickly.
And we have a question. Do you recommend treating with acyclovir initially on everybody?
Oh, that's a good question.
That's a really good question. So it depends on patient to patient, you know, how I think about it. But in my case, if I worry about enough to order the herpes test, then in my head, I better treat the patient. Yep. So if I have suspicion enough to, you know, getting history of herpes, cold sores, you know, I'm really worried about that being one of the culprits. And if I order the test, in my mind, I better treat the patient until I get the test results back.
Right, and it's better to order it. If you get an LP, I order it every time, because if you don't order it, then if everything kind of comes back negative, then you'll say, oh, I wish I ordered it, and you'll call the lab and say, do you have any extra CSF fluid so I can add it on? I wouldn't order an antibody test. So many people have HSV1 or 2 antibody positive, that I wouldn't order it. And also, I would never order an HSV IgM antibody. So that usually an IgM will tell you if they've been recently infected with HSV, but it's not great, and it can stay positive for many years. And so sometimes people will say, oh, you just, the HSV IgM antibody is positive, so you probably recently got it. And that's not the case.
Yeah, because herpes likes to hide out in your nerve root. So every time you reactivate, you're going to have IgM positive. But so if you think it's in the CSF, you're worried about herpes, encephalitis, meningitis, test of choice is PCR for herpes 1 and 2. If you're going to order that, then treat the patient with acyclovir. You should get the test result back within 24 hours to 48 hours, and then you could stop.
And if you're concerned about it, we can ask the patient, do you get cold sores, or are you having a current outbreak, whether it's on their lips, just cold sores, or a genital outbreak? Yeah. But some doctors don't know about antibody HSV IgM antibodies, and so they'll give the wrong information, and they'll say, you just recently got this, and then they'll get a divorce, and then they'll blame their husband or wife, and it wasn't their fault at all. The doctor just gave them the wrong information. So that's really a tragedy when that happens.
Any other questions you guys have? Well, thank you very much. And please email us and let us know if there's any other topics that you would like us to cover for next month. Thank you.
Yeah, thank you, everybody. Have a good day.
Yeah.